Hi everyone, I am going to present on an hour of tissue integrity before we have class together. So the purpose of this is for you to view it prior to coming to the class. So I am going to present on slides 1 to 19, then 88 to 105. I'm sorry, 88 to 107. So let's begin. So these are our objectives that I will let you view. And our let's break it down. So it's a total of 4.5 hours. 1 hour is online. So you'll have the 3.5 hours in class. It's on exam 4, and your reading assignments are there. And we have this is the pre-recorded PowerPoint. So to start, we're going to go over the integumentary system. And this is a review from your A&P class. So skin is the largest organ. You guys should remember that. And the function of the skin is it acts as a barrier, which it protects us from the outside environment. So it protects us from injury, from infection, from all the pathogens from entering. If you think back to infection, the portal of entry, the skin prevents bacteria and fungus and viruses from entering. If you think of that. It acts at protects us from UV radiation from the sun. It helps us maintain our heat in the fluctuations in temperature, so regulate our body temperature. Um, it also allows us to perceive touch, pain, pressure, and vibration. So when someone touches us, it stimulates the nerves to let us know that we're being touched. When there's pain, which pain is a protective mechanism. So it will lets us know when we're having pain. So for instance, if we're having pain in our butt, it lets us know so we can shift and not get a pressure injury or or a sore on our bottom. With pressure, it notifies us in any vibration. So um, it also helps us eliminate waste, and that's through sweating. Um, it helps support the synthesis of vitamin D. We get that through the sun, so helping that as well. So you guys can think back to your A&P class, but the skin, it's the largest organ. We don't always think of it as an organ, but it is, and it serves a lot of functions for us. The skin anatomy and function. To go a little further, we have the different layers of our skin. This first layer that you can see is the epidermis. That's our outermost layer. That's the part of the skin that we see when we look at someone. And that helps prevent water loss from our skin. It protects us against the infection. So again, that portal of entry, we're closing that gap, thinking back to infection, because all of this stuff is connected. It protects us against injuries, protect us against sun and UV rays, and this is where we can detect very light touch. Then the next layer is our dermis, and you can see there that this has a lot of capillaries, blood vessels. There's some lymph tissue. Sometimes there's some connective tissue. So you're getting more into the thicker layer of the skin. It's underneath the epidermis. And this is what gives us our skin strength and flexibility, and it provides nourishment. So to the epidermis. So think about the food for our skin. That's like the oxygen, any minerals, nutrients, anything like that for the skin. This is what provides it, the dermis, because you don't have any of those capillaries in the epidermis. So that's where it gets fed. And then after the dermis, we have the subcutaneous layer. This is our adipose tissue, our fat. And that's underneath the dermis, and that's really where our insulation comes. So think about a house's insulation. Um, if you think inside the house, people put insulation to keep their house warm. So when they have their heating system going, the heat doesn't just fly out the walls. So that's the same thing with our subcutaneous layer. That's our heating system. That's our temperature regulation. It helps keep us warm. It keeps us at the 98.5 or whatever our body temperature is. It helps absorb shocks, like if you're going to be pushed to the ground. It takes some of that pressure, that shock away. It also pads our internal organs, so it protects our organs as well. So if we were to get hit, like say if you were to get a baseball to the gut, to the stomach, that will absorb some of that like force, that shock that comes with the baseball, and coat and protect our other organs there, like um, our GI tract or whatever else there. And then we have preventions of alteration to skin integrity, client teaching. So, knowing about so we just talked about our skin and the function of our skin. So, how do we prevent it from having an alteration? So, how do we keep it functioning? And what are we going to teach our clients? So, going back, if you look here, we talked about this synthesis of vitamin D. So we get that in also protection of the ultraviolet radiation. So the ultraviolet radiation, what that means is the sun coming at us. So what do we need to teach our clients? Because too much sun, you're going to get too much that ultraviolet radiation, and radiation is harmful for us. So we need to teach our clients that to help prevent any alteration, any damage to our skin, that they need to limit their sun exposure, wear sunscreen, sunglasses, because sun can damage our eyes as well. Long sleeves when there's going to be extended sun exposure or if they're very sensitive to it. Large brimmed hat to protect their faces. Avoiding sun from 10 a.m. to 2 p.m. at the peak hours. And then be aware of any photosensitive drugs. So at this point, you guys have had lectures and you guys have heard that some medications are photosensitive, meaning that people cannot go in the sun if they take those. A lot of our antibiotics, like thinking back to elimination, thinking back to infection, ciprofloxacin, you want to avoid Bactrim. You want to avoid sun exposure when you're on certain medications. So what else do we want to teach our clients? Irritants and allergens. So any harsh detergent you want to avoid. A lot of like lye-based soaps can cause damage, can cause irritation to people's skins, and even cause burns if it's not, if it's too harsh. People may need allergy testing. Sometimes they may be allergic to the tape that we use in clinical, either on an IV to tape the IV in place, or maybe to tape a dressing in place. So being aware of that, maybe use paper tape because paper tape won't rip the skin off as much. And then for our nutrition, some things that we want to think about are any supplements that people may need. Any nutritional supplements. You guys talked about some of those in nutrition, some supplements that may be good for skin, like, your omega-3s are usually pretty good for that. And for wound healing, protein is good for wound healing. So just thinking if they do have an alteration, if they have a big wound, maybe they have to increase their protein, or what will they need for their skin to heal. Do they need a nutrition consult? Are they malnourished? Because your body's not going to be able to provide the nutrients to their skin if they're not taking the nutrients in. Maybe they need help eating. Do you have to assist them with meals? Think back to the beginning of the semester when we talked about, feeding clients, nutrition, those kind of things. Are they getting enough fluids? Because if you're dehydrated, your skin also gets dried out, and then your skin's easier to break down and less likely to heal. Skin hygiene. You want to make sure that you're not leaving the skin soiled, that you're controlling any moisture that goes along with like incontinent episodes. Afterwards, you want to provide a barrier cream, and you want to think if anyone has any babies, if your babies or your babysat or whatever had a diaper rash, you would clean it let it dry and then put the barrier cream or the diaper cream on their bottom to help it heal, because you don't want to lock the moisture in against the skin. So you want to make sure that you're keeping their skin nice and dry, providing those barrier creams. We shouldn't be using those briefs or adult diapers because those are just going to soak that moisture in right against them. We need to be assessing our patients' skins, their skin. We do a full skin assessment upon admission every shift and as needed. Make sure we're relieving any pressure. You guys can think back to safety. When you learned about like reposition in patients, how important that is to relieve the pressure every 2 hours, because our bony prominences can cause a pressure injury as a result. Avoid friction in sharing, and we do talk about that um, as well, and what friction is versus what sharing is. Um, and then um, smoking cessation. So that's important. You guys probably hear this every lecture, but smoking is also harmful for our skin and more at risk for skin cancers. Now, going back to when you guys first learned how to do your nursing assessment, let's think back to those days that seem so long ago. So, thinking about some things that you're gonna do for the integument or your skin assessment. Just like everything, you want to get a little bit of that medical history. Do they have any history of any skin issues or anything that would increase the risk of skin issues, such as smoking or as a history of a skin cancer, or maybe they have paraplegia and they um, are now, so now they have decreased movement and sensation in their lower extremities, or whatever it is, whatever pertinent information is. Um, you want to make sure that you have a well lit room. Natural light is better. So if you can have the sun exposed, it's easier to see, but you want to make sure that it's nice and bright in the room when you're assessing their skin. We're looking for any changes in the color of their skin. So that could be like due to like a disease or a nutritional deficit or anything like that. If there is a change in their skin color, that would be something that you would want to know. You want to make sure it's individualized, because what is normal for one person may not be normal for another. Um, you want to use your Braden scale and identify if they're at high risk for skin breakdown and what their risk factors are for skin breakdown. You want to then go ahead and start looking around and assessing their skin. We look at their skin, their scalp, their hair, their nails. Um, we're assessing for symmetry as well. That the color of the skin, the pigmentation of the skin should be consistent throughout the body. Um, the darker areas of their skin are generally the areas that are more exposed to the sun, and it may be lighter in the areas that don't get sun exposure. So, for instance, usually like the palms of the hands might be a little bit lighter, the nail beds, soles of the feet, those kind of areas are generally lighter skinned, lighter pigmentation, have lighter pigmentation. Questions you can ask the patients. Have you noticed any changes in your skin? Have you had any rashes? Do you have any dry or is your skin dry skin or oily skin? Any new moles or lesions, changes? Um, we want to then look around. Do they have any abrasions? Do they have any open areas? Do they have any rashes? Are you seeing excessive moisture or evidence of dry skin? Do you see any edema present? Um, so is their skin smooth or rough? Do they seem to have thin skin or thicker skin? Is it tight, like really taut or tight, or is it supple, meaning like the opposite of tight, like as if it's like like almost like rolled skin. Um, do they have sometimes skin texture? So that all goes along with the skin texture. Um, can be changed as people get older, or if they've had a trauma injury to that area or a surgical area. like a healed incision, or if they do have any open wounds or any presence of dehydration, that can all impact the skin turgor. Um, Now for I'm sorry, the skin texture. Now for moisture, again, is it dry or moist to touch? Um, do they have any eczema or dermatitis, like an irritation of the skin? Any psoriasis, any rashes, swelling, going to the temperature? Um, Sometimes when people have inflamed and irritated skin, it will get warmer, so you want to look for that. If it's cooler, if you touch the skin and it's cool to touch, generally that means they don't have enough blood flow. So you want to think about that as well. A normal temp, what we would describe as normal, would be warm skin, nice and warm. So we usually say like warm, clean, dry, intact. Color of the skin. So um, there's some different terminology to describe what you really want to look to make sure is it's consistent throughout their body, the skin color, that they it's consistent with like their ethnicity. The other thing is, we sometimes describe people who have pallor skin, Pallor, and that means the loss of color. So, um, someone who is pale skinned like myself, um, when you would say, if you were to say Kayla has pallor, like she has pallor skin right now, that would mean like someone with pale skin, they kind of lose that red undertone. Like, so, you kind of lose that redness in their skin color. Someone who has like black skin, when they have pallor, their skin color can turn more of a grayish color. Especially you'll see it in their mucous membranes. And then someone who has like a browner skin pigmentation, sometimes when you describe them as pallor, you'll see more of like a yellow brown tinge in their skin color. Um, these changes, pallor, can happen due to anemia or shock. It can be all over their body, or you may just see it in like their lips or their nail beds or the mucous membranes or the conjunctiva in that eye. So, pallor means loss of color, and I described the different ways you would see it in some different pigmentation, some different skin colors. Now, if someone has cyanotic or cyanosis, that's like a bluish grayish color. And you'll see it like more bluish in a lighter skin pigmentation. Um, sometimes someone who has a darker skin pigmentation, you may see it also as like the yellow brown or like a grayer color. So you want to be aware of that. Um, on someone with a darker skin tone, you may also see a bluish color on the palms of their hands or the soles of their feet. So I just think it's really important that we know how to assess all like a variety of people. So that's really important. And when someone it has cyanosis, that's due to inadequate oxygenation. So our oxygens are food for our body, food for our organs, and including our skin. And if you don't have enough oxygen to feed your skin, it's going to start to, it's going to start to suffer. And if you don't have enough oxygen, you turn blue. So like that's what you see. Um, Jaundice is like a yellowing or like kind of it's more of like a yellowy, sometimes an orangey skin pigmentation, and that's due to a liver issue. It's due to excess bilirubin, which is due to your liver or your gallbladder not working correctly. And when you see someone jaundice, so someone who has like paler skin like me, you'll see it in their skin more easily. So I do have a video that actually I share it with Fabi. So I think that Fabi plays it for you, and it's how to assess jaundice in someone with darker pigmentation. And so I want you to think back to your physical assessment because I think this is important. One, you can see it in the sclera, which is the whites of the eye, but the other thing is you can push down on like the nose and see like the bridge of the nose, and you can push down. And when you push down, if it's yellowing, that could be an indication of jaundice. I think you can also do it to the soles of the feet as well for someone who has darker pigmentation. Erythema, um, so Erythema is a redness, and that that would be like if you saw redness in their skin their skin color. Now, this is also harder to assess in the darker skin tones. So, one way you can assess for this is by palpating for warmness, because if someone has erythema, if they're red skin, usually it's a warmer skin color as well. And you would compare it to different sections. So, like if I had erythema on my elbow, that would be warmer, but like if I didn't have it on my arm, it wouldn't be warmer. So it's like a localized thing. Um, now, in darker skin tone, it may be like a deeper brown color or like a purple color, but it would also be warm. So that's another way to assess it as well. This is due to fevers, trauma, blushing if they get like kind of red in the face, or getting really flushed. Infection, it can be due to alcohol or substance use. Pressure, if you like cross your legs for a really long time and get up, there's usually like, that redness where your legs were touching from the pressure. Or it's also due to an inflammatory response. Now, ecchymosis, ECCHYMOSIS, is bruising. And, bruising is like, a collection of blood underneath the subcutaneous tissue underneath the skin. So, it's usually a purple discoloration. It changes as it heals. So you want to note the color, the location, and the size. Now, I know you guys are assessing all of this stuff in clinical every clinical day, but just to continue as a review, your skin turgor is uh, assesses for like the elasticity of the skin. If you have poor skin turgor, that means dehydration, or sometimes people who are older, they have looser skin, and that could be due to age as well. Um, And if you have poor skin turgor, meaning like you pinch and it stays tented, um, people with that are more susceptible to skin breakdown. So they're more likely to have a skin issue as a result. Now, edema, I know you guys have heard this, like, you get it in F&E, you get it in all sorts of places. So edema is that fluid, interstitial fluid. So swelling um, you know, in places that you're not supposed to have swelling. And your skin usually gets shiny, it can get tight. Um, Pitting edema is when you push down and your fingerprint, the skin stays indented. Let me see if I have the scale. Yep, we'll go talk about the scale next. And then brawny edema, BRAWNY edema. There's no indent, but it's like really hard and shiny. It's weepy, meaning there's like moisture dripping from it, and it's warm. Now, pain assessment of the skin. So you want to make sure that pain at any pressure sites, if there's any pain at any pressure sites, that could be an indication that there's going to start being a pressure injury. So you want to make sure that they're not having pain there. If they are, you want to make sure that you're doing preventative measures so they don't get a pressure injury. And then, as always, we have them complete the Braden scale. So this is the edema chart. Now, the way I always say to remember, what does +2, +1 mean, +2, 0, whatever. If they have 0, 0 times 2 is 0. So that means it's 0 millimeters deep. If they have 1, 1 times 2 is 2. So it's 2 millimeters deep. If they have 2, 2 times 2 is 4 millimeters deep. 3 times 3 is 6. 3 times 2 is 6. 4 times 2 is 8. So you really just double each one, and that's how many millimeters you're gonna get. So, 0 times 2 or 0 plus 0, either way you wanna look at it, is 0. 1 plus, I'm sorry, 1 times 2 or double it, 1 plus 1 is 2. 2 times 2 or 2 plus 2 is 4. 3 times 2 or 3 plus 3 is 6. 4 plus 4 is 8, or 4 times 2 is 8. So you just double it each time, and that's how you're going to know the definition of what plus 1 is, plus 2, plus 3, plus 4 is. Just meant to be a little trick. Now, brawny edema. So this isn't something everyone has always heard of, so I like to talk about it a little bit. Brawny edema is a change typical of chronic venous insufficiency. So your veins, you want to remember, bring the blood back, the dirty blood. So the arteries have the clean blood, the veins have the used up blood. So when your veins don't work well enough, you can have this venous insufficiency. And this is a picture of brawny edema. You can see it's like this brown, darker pigmentation. It looks really tight. It's shiny. It's probably weepy. Um, when you palpate it, there's no real indentation, so it's not palpable. It's not pitting. Um, the excess fluid, it really can't be displaced. So, like, meaning like when you push down on pit and edema, you're displacing that fluid until it comes back. With brawny edema, you're not really able to do that. Um, the brawny color, that like browny red color, is due is causes because red blood cells are actually like burst open, um and there is chronic ischemia, so like there's not good food being fed to the skin. Your body's not giving it enough oxygen, so you're not feeding your skin well enough. Um, so it's non-pitting, it's hard, thick, shiny, warm, moist, weepy, red or dark maroony colored. These can end up having ulcers on them, and like you can kind of see on the inside of the foot right there looks like there might be some, and those are called venous ulcers, which we do talk about. Now to talk about our nails. Um, so you guys know from doing clinical and your assessment class, you guys, to assess fingernails, you're assessing for the strength, um, and any changes are an indicator of the health, nutrition, occupation as well. My husband's fingernails, they're always like cracked, broken, whatever. He does a lot of physical labor. um, and the level of self-care, if they're kept neat, short, clean. um, and we do not cut patients' nails, especially diabetics. Um, they can use like nail filers, but we don't use any nail clippers for diabetic patients. And diabetic patients should be seen by podiatry. Normal nails are going to be pink, convex, and evenly curved. They should be smooth and transparent and well-rounded, and the nail bed angle should be 160 degrees. So you can see up in the top part of the picture, the normal nail bed is like 160 degrees. Capillary refill, when you press down, it comes back in place within 3 seconds. Um, Now, if it's a flatter nail bed, that's would be like if it's like 180 degrees, it's flatter. That's an indication of early clubbing. And if it's greater than 180, that's late clubbing. So you guys can think back, to clubbing, which I'm sure you guys have heard of that. That's like a chronic issue with their breathing. They're not getting enough oxygen to their fingers, so it's a chronic issue. Now the assessment of our patient's hair. So you want to look at the distribution. Is it evenly distributed throughout their scalp? What's the texture? Is it normal for their age, their sex, their genetics? Hormonal levels and health status also affect that as well. You want to look for normal findings. It would be resilient, evenly distributed, no excess oils or dryness. Any deviations, two examples. One is alopecia, and that's what this picture of is when you have hair loss. And the other one is hirsutism. Um, and that is when women have excessive growth of like coarse, like dark coarse hair, like almost like a male pattern hair in women, and they could get hair in their chest, their face, like a mustache or like a beard, and their back. So it's usually due to like getting having too much of the male hormones in their body. Um, then the scalp, yeah, any dryness, lumps, lesions, or any lice. I've had patients with lice, and it is nasty, but just I just feel like I always itch afterwards. It's not like I mean, I don't know, kids get it all the time, but like whenever I take care of someone who has lice, I like constantly feel like I have to itch afterwards. So it's not, I guess, nasty in itself, but it's makes you feel like you have it afterwards because they jump around. But anyways, I digress. And then risk factors for impaired tissue integrity. So, who are some people that are more at risk to get a tissue injury? So, our young patients, they have very immature skin. They're more at risk for maceration and dermatitis. So, if you have kids, you've babysat kids, or you've ever known a kid in your life, um, they, if you put them in the tub very easily, they get that very quickly. They get that like wrinkly skin. So they're high risk for maceration. They're very sensitive to the moisture and dermatitis, easily get rashes and skin injuries. Um, when that I remember my oldest son, he had like a constant diaper rash, and I used to have to like let him lie around naked because the diapers held so much moisture that I either had to change his diaper almost every hour or give him periods of time of just being naked because he kept, when he was like a newborn, he kept just having like a really bad diaper rash. Um, and so the dermatitis, it's come when it's exposed to some sort of irritant like feces or urine, or like if someone has a wound secretion that's like oozing out a ton of stuff, that could do it as well. So our young patients, they just have a really immature skin, very sensitive. Now our older patients, this is what we'll see in 101, our older adults. As people get older, which we do have a slide about aging, our aging adults, their collagen stores decrease and their skin thins, so they have less elasticity in their skin. Now, if your skin isn't as elastic, it's not as bendable, it's not as movable. So you're more at risk for skin tears because when you bump it up against the table, it's not gonna like bounce around. It's just gonna tear open, and it's really thin as well. So they have more skin tears. They have more tissue trauma as a result. Um, they have drier skin, um, and like I said, the skin tears. Then our patients who are immobile, that could be due to like any form of immobility, paralysis, whatever. They can't reposition themselves as well, so they're stuck in the same position, and being in that same position puts pressure on certain areas that can then increase their risk for impaired tissue integrity. Malnutrition, we're not feeding our skin enough. So if we're not feeding our bodies enough, there's not enough nutrients getting to our skin to keep it healthy, to keep producing new skin, and so we can end up with an increased risk for skin breakdown, as well as our muscles will start to break down. So um, that's another component of it as well. People with chronic diseases such as liver disease, kidney disease, cancers, they cause skin frailty. So the skin is frailer, it's not as strong. Our patients who have sensory loss, they may not feel when their skin is getting damaged, and then it gets really, really bad, and then they realize. So they're not aware of the pressure that's on their foot, so they don't bother to move it, and a little wound happens, a big, big, big one, and they don't notice until it's really big. Incontinence, so moisture sticks to the skin, it causes maceration, it causes dermatitis, skin breakdown, so that can impact our skin as well. Fevers. So a fever increases the tissue metabolic demand, so the amount of energy that the system needs. And it also causes diaphoresis or sweating, and so that will leave the skin moist as well. If they already have an existing pressure injury, you should not be positioning them on that side. So if I have a pressure injury on um, my right hip, and I'm on that side, and you position me on my right side, that side won't heal. So now you can only position me on my back or my left side. So you are going back and forth to only two places instead of to the right side. So now as a result, you have more pressure on your left side and your back side. So you're more at risk for pressure injuries there because you don't have the 3 points to reposition to. Edema. Um, So when someone has a lot of edema, they're more susceptible to pressure injuries. They can't handle those pressure points as well. They have more friction, they have more shearing. So as a result, they are more susceptible to skin breakdown. Dehydration, people tend to lose their elasticity and skin turgor with dehydration. So when you have poor skin turgor, poor elasticity, you will have more tissue, more skin damage as well, whether it's a skin tear or a pressure injury, whatever it is. Anemia. Anemia, there's not enough oxygen being carried throughout the body because the oxygen binds to your red blood cells. So if you don't have enough red blood cells for the binding, you're not carrying enough oxygen throughout your body. So you're not feeding your skin as much as you should because oxygen is a food source for our body. And then the circulatory disorders. So when you have a circulatory disorder, it reduces the perfusion or the feeding of our skin. So our skin isn't getting enough oxygen, and again, that's the food for our skin. Client populations in the skin. So I put these into like a table over a few slides because I thought it was an easier way to view this material. So you guys learn a lot about neonates and children in 201. So it's really not the focus here, but it's good to know. So the different changes that they have as a result. The ones I really want to focus on are the patients that we're going to see in fundamentals. So our older adults, their skin is thin, they have decreased elasticity, decreased subcutaneous tissue, decreased blood supply, and decreased hydration. Due to those, they're going to get skin tears, pressure injuries, itchy, dry, flaky skin, and skin infections. Now, our patients who do not move as much, they have reduced circulation. They have alterations in their thermal regulation. They're incontinent more likely. They may have loss of collagen in their skin. May have muscle atrophy. They may have impaired sensations. So as a result, they'll have the skin tears, they'll have the pressure injuries, they'll have the skin infections. They can have dermatitis as a result of the incontinence. So again, just to emphasize the older adult, because we talk a lot about the older adult in 101, it's one of our focuses. So they have a thinning epidermis. So that epidermis, that outer layer of the skin gets thinner. They lose the subcutaneous tissue over their bony they lose their subcutaneous tissues over their bony prominences. So they're more likely to get a pressure injury there. Their skin is not as strong. It's not as doesn't have as much elasticity, as much bend to it. They have less nerve cells, so their nerve cells aren't communicating to their brain that, there's a pressure, there's an injury, whatever it is. They have decreased blood supply to our nail beds. The skin gets drier, it gets scaly, it gets wrinkled. They don't have good skin turgor. Their nails get thicker, they're slower to grow, they're brittle, they break easier, they get yellowed. So as a result, they're going to have those skin tears. They're going to have the tissue trauma. They're going to have, if they do get a wound, it's not going to heal as quickly as other people. Um, they're more likely to get an infection in a wound or a skin, in their skin. They're more susceptible. They have more damage when they have trauma. They're more likely to have malignant lesions, cancerous lesions as people get older. They're um, more likely to have pressure injuries. If you give a med the sub-Q route, it's going to be a slower absorption of the med. They're going to have increased risk of nail splitting and infections of the nail. So the next population that we talk about, so we have clients who have obesity, um, and they can have drier skin. They can also have more susceptible to maceration or wet skin as well. They have elevated skin temperatures and decreased blood and lymph flow. So they're not getting as much circulatory as well as lymph. So they're more likely for skin tears, pressure injuries, if they have diabetes, diabetic ulcers, moisture lesions, skin fold rashes. Because when someone has obesity, if they have skin on skin, skin folds, they'll rub up against each other and they can have moisture and friction created as a result. People who have cancer, may receive radiation, and that can result in inflammation, skin surface damage, and decreased blood supply. So as a result, they have pressure injuries, delayed wound healing, skin infections, and radiation-induced dermatitis. Now, any other chronic illnesses, this could be liver diseases, kidney diseases, heart diseases, poor nutrition, a stoma. So in elimination, we learned about the stoma from the ostomies, that the part of the organ that's out on the abdomen. Psychosocial issues, and those all increase the risk of skin tears, pressure injuries, infections, and moisture associated lesions. Part 3 of this. So other things that can cause client groups that can cause skin alterations. So malnutrition, sensory loss, incontinence, fevers, and edema. With malnutrition, this could be they may be losing a lot of weight as a result of their poor nutrition. Their muscles may be breaking down, so they don't have as much cushion between the skin and the bone, and that will increase your risk for pressure injuries. It also impairs the ability for the wound to heal, and that's like, you need nutrients for your body to heal. You need protein, you need vitamins, and minerals so your body can heal from a wound. Sensory loss, you may not, like, again, you won't have that discomfort from being in the same position or getting a sore, so your body doesn't know until it has an injury, so you're more at risk for those types of injuries. Incontinence, so you're going to have excoriation, you're going to have maceration, you're sitting in wetness. Stool has a lot of acid in it, so that's really harmful for the skin as well. So you have more likely for dermatitis, for yeast infections. And then fevers, again, you can sweat, get the maceration. You have more work on your body, more needs your body needs when it has a fever, more caloric needs, more nutrient needs. And so you're prone to pressure injuries, friction and shearing. And then edema, your tissue isn't as tolerant of pressure. It's more susceptible to friction and shear. And so you have those injuries as well. Now our last ones are these: dehydration. Again, you have the poor skin turgor, You don't have that bendability of your skin, so you're going to have your wounds won't heal as well. You'll have more pressure injuries. An existing injury, you limit yourself, you can't position on to that injury, so it's harder to reposition, so you have more pressure injuries as a result. Anemia, poor oxygenation to your skin tissue. We said this already. As a result, you can have pressure ulcers, poor wound healing, and then circulatory diseases. You're not feeding your skin. You don't have enough perfusion or oxygenation. So you have pressure injuries and poor wound healing as a result. So now, what are wounds? Wounds are defined as disruption in the normal composition and performance of the skin and its underlying structures. You can have an acute wound, which would be like a shorter term wound, and that could be intentionally or unintentionally. So why would we have an intentional wound? Think like a surgical incision. You had a C-section, you have that wound, that incision, you had your knee replaced, you have that wound, it's an incision. Um, then you could also have an acute unintentional wound, and that would be a traumatic injury. You burned yourself, a gunshot wound, a puncture. So anything like that. They could also be traumatic wounds. They could be like surgical wounds or moisture associated as well. There's also chronic wounds. So those um, develop over time due to a disruption in the wound healing when it is acute or due to conditions which cause alterations in the blood flow. So you have a wound and it doesn't heal, or you have a wound and your body can't heal it because you don't have enough blood flow to feed the skin, to feed the wound so it heals. Remember, our blood carries the food that our body needs. So these can be venous injury, venous diseases, arterial wounds, neuropathic wounds, um, some blood flow conditions that may result in a chronic wound. A longer term wound could be chronic venous insufficiency. So your veins aren't working that well. Chronic peripheral arterial disease, your arteries aren't working that well. Um, Diabetes is another one. Um, when people smoke, if they're malnourished, immunosuppressed, they're immobile, and they have an infection in the wound, then those are all factors that are going to lead to a chronic non-healing wound. So again, the acute wound develop as a result of an injury, typically like a trauma, or the chronic wound, they develop over time, or they don't progress to healing. So wound assessment, we will follow this up in class, how to assess the wounds that we take care of. So moving on to slide 88, factors which influence wound healing. So factors that affect wound healing can be remembered easily by the mnemonic didn't heal. So D, diabetes. Someone with diabetes, it's harder for their wounds to heal due to the nature of the disease process. I, infection. If it's infected, you don't just have the integumentary system to heal. You don't just have the wound itself to heal. You now also have to fight the infection, the pathogens that has invaded the wound as well. D, drugs. If you're on certain medications, it can decrease wound healing as well. So you want to look at what medications are on and if it's going to impact their wound healing. And nutritional problems. If they have poor nutrition, maybe they have poor protein intake, that can impact the way the wound heals as well. T, tissue necrosis, death of the tissue. If some of the tissue is dying, that means you now don't just have to have the wound that heals, but you have to heal the dead, you have to get rid of the dead tissue because it's not going to magically come back to life. H, hypoxia, you're not feeding your wound, you're not feeding the skin to heal. You're depriving it of the food, oxygen. E, extensive tension. So there's a lot of tension on the wound, um, a lot of pulling on the wound. It's not going to heal as well. A, if there's another wound, the more wounds you have, the harder it is to heal, and that's for a variety of reasons. Why do they have the wounds? But also now they're competing with each other to get the necessary um, supplies to heal itself. L, low temperatures. Um, you need to have an optimal temperature for the wound to heal. It needs moisture. It needs the right temperature, the right pH. It needs the correct environment to heal. So other factors that affect wound healing: age, harder to heal wounds for our young and our old. It can delay wound healing. They have less skin turgor, the skin is frailer, poor circulation and oxygenation. The tissue doesn't as easily regenerate or grow. They don't have as much collagen. Their immune systems aren't as strong, and they're more susceptible to dehydration. Um, then the circulation and oxygenation, hypoxia. Um, so if someone has had one example could be is if someone had a lot of blood loss when they had this wound, they now have poor oxygenation, and because they don't have the oxygen carrying capacity, and the way the body compensates to a large amount of blood being lost is the veins get smaller. The vasoconstriction happens, narrowing of the blood vessels. So if that's the case, you're not feeding the wound as much. You're not able to give the nutrients to the wound when it needs it. Smoking impairs oxygenation and clotting as well. So those are also things to think about as well. Um, Other factors that we need to think about: medication and health status. Corticosteroids are prednisolone, solumedrol. All of those are steroids that that can delay wound healing. Um, Radiation causes cells to be destroyed, and they suppress the immune system. Same thing with chemotherapy. Chemotherapy targets rapidly growing cells. So if you're trying to heal a wound, the skin is going to grow rapidly. So it's going to, if you're on chemotherapy, it's going to target those cells. So it's not going to heal as well. Chronic illnesses, um, prolonged antibiotic use, liver disease, diabetes, immunosuppression, all of those are going to delay wound healing. Another thing to think about is someone is on aspirin. If you think back to your clotting and bleeding, aspirin makes your platelets not sticky. So if your platelets aren't sticky, you have a wound, you're going to be more at risk from bleeding from that wound. Nutrition as well, poor nutrition, as we said. Here we go with more of the nutrition. So you need, for a wound to heal, you need protein, you need vitamin A, vitamin C, zinc, iron, and fluids. So when you think of protein, you're going to be thinking of like meats, fish, peanut butter, a lot of those protein rich foods. Vitamin A is big in leafy green veggies and orange and yellow veggies. Vitamin C is in citrus. And then zinc is in a lot of oysters and red meat. Iron is heavy. You have a lot of that in spinach and red meat. And there's a lot of iron supplements as well. And then they need fluids. to heal as well. We need to keep that wound bed nice and moist. Multiple wounds. If someone has a multiple wounds, just ask for a nutrient. They compete for nutrients, so you're going to need lots of nutrient supplements. So they're definitely going to need some sort of supplement there. Infection, more vulnerable to damage. Presence of a foreign body. That picture is supposed to have a foreign body in it. Looks really gross, huh? A foreign body. Think back to your infection lecture, guys. What did you learn? The foreign body, the chain of infection. Think about it. You have the foreign body that brings in the pathogen. So now you have the portal of entry, and the foreign body brought in the pathogen. Tissue necrosis. If tissue is dying, clearly you don't have enough blood supply. So you're not able to feed your body. So that's something you want to think about with your wound healing. Types of wound healing. So this is important. You should know your different types. So you have primary healing. That's when there's clean lacerations or a surgical incision, and we close it with adhesives or sutures. So the doctors pinch it tight. You can see in these pictures primary intention. You have this nice, clean, straight incision. They put a suture. Maybe they do the Dermabond or the surgical glue or staples, but the doctor is closing it together. It's a clean incision. It's closed. Secondary intention or secondary healing is the wound is left open to heal, and then you have the granulation or the healthy tissue growing in, and it will start to heal itself. Then you have delayed primary closure, and that's when you have both. You have it like opened, and then you close it. So you have it's also used to be called tertiary intention. You have your wound, it starts to grow its granulation, and as it grows, you're gonna close the suture later with a suture later on. So that's an example of primary healing, primary intention. So just a picture of it, you can see there's sutures as well. It looks like there's some glue on it as well. So the doctor closed it themselves. Secondary, you can see there's some granulation tissue. So that's that healthy tissue growing in, and it's going to start to heal itself. So phases of wound healing, you should have an idea about this. You have 3 phases of the wound healing. You have the hemostatic or inflammatory phase, proliferative phase, and remodeling phase. So the first stage that happens right away. Sometimes some sources will separate this one into 2, but we're going to combine it into one, the hemostatic and inflammatory phase. That happens as soon as you have the injury. It lasts 3 to 6 days. And that's when you have the inflammation, the blood vessels constrict, there's tissue damage, they release some protein, and that's going to cause clotting. So this is when you get the blood clot, you get the scab, you're trying to stop the bleeding. Once the bleeding's controlled, you'll have more, you'll start to have the swelling there as well, because the white blood cells are going to go there and start to do its job. White blood cells are cleaning the area. Then you'll start to have some new formation of the new keratin. You'll start to get new blood vessels formed. So what you really see here is redness, swelling, heat, sometimes in like drainage. Now, after the injury, like 3 to 6 days later, you enter the proliferative phase. That can last a few weeks. You have more blood supply now. The granulation of the tissue is starting, so you're starting to heal it. There's going to be collagen, so the wound's going to start to get stronger. The wound will mature, it will close. Here, it's not normal to see the red. So in the first stage, if you initially have a wound, it's normal to see red. It's normal for it to be warm. It's normal for drainage. Think about if you cut open your arm initially it's going to be red around it. It's going to be warm. It's going to be drainage. But then after a while, it shouldn't be. You shouldn't see pain. You shouldn't see heat. You shouldn't see warmth. It shouldn't be swollen. All of those things should improve. So if you see those 3 weeks after the initial injury, you're going to start to get worried about why is that doing that? Is there an infection or what's going on? Now, the remodeling phase begins next. And this can last up to more than a year. Can be a really long stage depending on the wound. And you should not be seeing swelling a year later or 3 weeks later or 4 weeks later. You should not have any more drainage or any more redness or any more heat coming from there. This is just, the scar is evolving, it's getting stronger tissue. So you just really want to think about like where they are in the stage, and if they see redness. Okay, so if I have a wound that's in the inflammatory phase, or if I have a wound that's 4 days old and it's red, are you like worried? Or is that normal part of that stage, as opposed to if I have a wound that is red and swollen 3 weeks later, is that normal? Complications of wounds. So wounds can have several different complications. We're going to talk about infections, dehiscence, evisceration, bleeding or hemorrhage, and fistula. Local systemic infections. So all wounds are going to have microbes, but not all wounds are infected. So it's going to depend if the microbe, the pathogen is able to take over the wound and invade the wound. We only give antibiotics for wounds that clinically look infected if there's other signs of infection. So if there's erythema around the wound, if there's warmth around the wound, edema, exudate, a foul odor, or the systemic systems. They have fevers, they have chills, nausea, vomiting. Their vital signs are affected: hypotension, tachycardia, tachypnea, hyperglycemia, their blood sugar's up, their white blood cells are showing infection, or if there's a change in mental status. Surgical site infections. These are infections related to an operation procedure near the incision site within 30 days of the procedure, or 30 to 90 days if it's a deep infection, a deep incision. Most common cause of these are a bacteria that's found in the nose or on the skin. So it's usually from the person touching it. And can be caused from the client's normal flora, the normal bacteria that lives on our skin, or during hospitalization. Having a bath before you have your surgery, having the patient cleanse with like a special soap, and then doing the right prep will prevent these infections. If you do get an infection, now think back to your infection lecture. Before you give someone an antibiotic, you need to get that wound collection, or you need to get the culture. So how are you going to culture it? The reason why we culture is to identify an infective organism and determine appropriate treatment. So you suspect an infection, so you're going to go get that wound culture. You need a sterile cotton applicator. First, you need to clean the wound with normal saline. You want it nice and clean, because all wounds are going to have some bacteria on the surface of it, some pathogens. So you want to clean it and see what's colonized there, what's actually like staying around and causing harm. Then you're going to use the sterile cotton applicator and get some of the wound drainage from the wound bed. So stick that cotton applicator, twirl it around from the wound bed. Do not swab the edges of the wound, but you want it really in that wound bed. If it's a really, really big wound, you can get multiple samples. You want to rotate the swab over an area of the wound near the center of the wound, doing like a light pressure, and so you can really collect some of that tissue, so some of that drainage. So not like deep pressure, just a very light pressure to get it. Now, you need to know the difference between dehiscence and evisceration. That is important. Dehiscence comes first. Dehiscence is when a incision separates, it opens up. Think about it's usually an abdomen that happens too. So think about if someone had a C-section and they have their C-section scar and it opens up. It's supposed to be closed and it opens up. That is dehiscence. The people who are at risk for this are someone who has a chronic disease, someone who's obese, someone who's older, they have abdominal cancer, their belly's bigger, they've been vomiting because of the pressure, they have a lot of straining from their belly, they're dehydrated, don't have enough nutrients, the sutures were ineffective. If they've had belly surgery, that's where it most commonly happens, or if there's an infection. To prevent dehisceration, the opening of the incision, can use like a cough pillow or a folded blanket when there's going to be pressure placed on that incision. So you use it to counter the pressure. If it happens, stay with the patient, notify the doctor, give any meds as needed. Cover the wound with moist, sterile dressing, sterile saline dressing. Start an IV, and they might need to go back to the OR to get it closed up. Put them in low Fowlers because that position prevents putting extra strain on that incision. Um, this is dehiscence. Look at these. The wound's separated, they're open. Now, evisceration is a step further. The wound's separated, and now you have organs hanging out. You have the intestines, whatever it is, it's hanging out. So, evisceration, the difference is it's a step further. The wound's open and the body's coming out. The organs are coming out. This is a very, very much an emergency. Never leave the patient. Put them in low Fowlers. They're gonna have to have surgery because their organs can't just hang out and about. Organs belong inside the body. So stay with the patient, get help. You want to never try to push back the organs. You don't play with them. That's not our job. Never try to push them back. Get help. Low Fowlers, so that's the 15 to 30 degrees. Make sure that you're getting them ready for surgery. That maybe starting the IV fluids, maybe getting whatever you want to get their vital signs. Apply a sterile saline soaked dressing over the organs. Remember, our organs are in the inside because they need to be moist. They need to be taken care of. So we want to make sure that we're keeping them moist so they don't actually die as well. Again, do not push back the organs. Do not start playing with them. Leave them where they are, but put sterile saline gauze over them. This can happen if someone has a suddenly increase in serous sanguinis drainage on their dressing. So all of a sudden they have more drainage. Right after they cough or they sneeze because of the pressure, the patient may also feel like something popped or gave way. So any of those, you want to start thinking about this. Now, another complication is bleeding or hemorrhaging. Bleeding could be internal or external. So you want to think back to bleeding and clotting. Lecture, actually, I don't know if you guys have had this at this point, but in bleeding and clotting, um, you want to think about someone could have a hematoma that can occur, and that's if blood clotting mechanisms fail, so like bleeding underneath. Um, so that could be that could cause a wound that's at risk for infection. That could cause a wound ischemia, necrosis, bleeding and hemorrhaging. So that you things you may see is swelling or distension, pain, drainage at the incision, but also think about vital signs, tachycardia, hypotension, those kind of things as well. Shortness of breath, any like anemia signs as well. If someone's on anticoagulants, that's a really big risk factor to having this complication. Also, obesity is as well. If there is bleeding at the wound, you want to apply pressure and cover with additional dressings, notify the provider, and keep track of those vital signs because too much bleeding does impact our vital signs, hypotension, tachycardia, tachypnea. So make sure you get the vital signs. You monitor signs and symptoms of bleeding, monitor the healing rate of the wound, but they might need um, an incision to drain. If it's like a hematoma, they might actually have to go in and drain it. Fistula formation. Fistulas are gross. So these are an abnormal connection between two internal organs, or between an internal organ and through the skin, um, outside of the body. So in this picture, you can see this is actually a Foley catheter going into a fistula in the wound. So there's like this, like, um, it like travels to a part of an organ. I don't know. I can't really tell where this one is traveling to, but it's a connection. Like, so maybe it could come through like the bladder into the skin or whatever. It's really gross. Um, so these results from disease, infections, or poor wound healing. Some signs that you would see is increase the amount of drainage, presence of purulent, um, presence of purulent drainage, or foul odor. Now, skin malignancies. This is the last kind of bit of what we're gonna do. So, to assess for skin malignancies, melanoma, there's the ABCDE rule. A, if it's asymmetrical, one half doesn't match the other. B, if the borders are irregular, ragged, notched, or blurred. C, the color is not the same throughout. So there's shades of brown, pink, black, red, white, blue, any other like differential colors. You can see these pictures, they all have like different shades of the colors. Diameter, if it's larger than 6 millimeters across. Evolving, if it's changing the shape, the size, or the color. That would be all examples of signs that it's a melanoma, and that is a tumor of the melanin forming of the skins. So that's a skin cancer. Um, in our population with in our clients who have darker skin with our black patients, melanoma can more commonly appear under the nail bed for those patients. So it's important to be looking at their nail beds. They're not as likely to get it like on their back or their arms or whatever, but where they get it is their nail beds. So that's something to be careful of and make sure you're looking at your patients with black skin for that. Warning signs: a sore that does not heal, um, the pigmentation spreads from the border to the surrounding skin, redness or new swelling beyond the border, changes in sensation, or changes in the surface of the mole. And this picture here shows someone with black skin, and you can see on the nail bed that would be an example of a possible melanoma, what you would be looking for. And these are the references. I will see you guys in class. Fun, more lecture and activities.